I'm Mike Ackerman, and I have the privilege of serving as the board of the SADS Foundation. As you know, SADS is for Sudden Arrhythmia Death Syndromes Foundation, and our whole purpose at the SADS Foundation is to help families live and thrive despite their diagnosis and to ultimately stop SADS. So we're delighted that you chose to join us for the next 40 minutes. And on behalf of Alice Laura, the CEO of the SADS Foundation, and her team, thanks a lot for your interest in this, and hopefully it's been of help to you to relieve anxiety, to encourage you, to provide answers. And today I am really excited to get to be joined by a dear friend of mine, a brother, Dr. Christopher Semsarian from down under in Sydney, Australia. So Christopher, thanks for joining us today. Good morning.
Thanks very much, Mike. It's an absolute pleasure and an honor to be on this live broadcast, and hopefully we'll learn some things together and entertain our audience.
Yeah, and as those who are joining, welcome. And Sherry, hi there. You're the first to give a greeting, so welcome. Bring your questions in. Just a couple of things this week, if we could try. If you could make your question tight for me so I can glance over and capture it. If it's a long one, it may just be too much for me to try to get a handle of to bring it to Chris's attention. So we're going to try to entertain as many questions of yours that you have related to your SADS condition, related to COVID-19 and your SADS condition. So we're in the midst, obviously, of the COVID-19 pandemic. We are just crossing 2.5 million cases worldwide and 170,000 deaths. In the United States, we're at 760,000 cases, and we just crossed 40,000 COVID-19 attributable deaths. Very different picture, isn't it, down under, Chris? What is it like there for COVID-19 so far?
Yeah, I think so far, Mike, we've been fairly lucky down in Australia. Our total number of cases, our population is about 25 million people, and we've had about 6,600 cases of confirmed COVID-19. And fortunately, 71 deaths. Of course, all of those deaths are important and very sad and tragic. But overall, from a public health perspective, I think we've done pretty well. And I guess the biggest thing we've done is we've gone into lockdown pretty early. So we've been in lockdown in Australia for about 4 or 5 weeks now, which means we only do essential activities outside of the home. So I'm, for example, basically working from home with telehealth clinics and only go into the hospital as needed.
That's great. Well, thanks a lot for dressing up so sharply for getting up this early in the morning. Really appreciate it.
I haven't dressed up in a suit for a while, so I quite enjoyed it.
Say, I know your society put out some important guidelines this past week, your society being the Cardiac Society for Australia and New Zealand, and you gave some guidelines, and a shout out to Belinda Gray, the guideline committee's first author. Hi, Belinda, if you got up this morning. But you made some important points that other societies have as well, and we did a few weeks ago, that you wanted to make sure SADS families were really aware of. And what would you say are the 3 absolute, don't forget, must remember things that you wanted SADS families to be aware of during this time?
Yeah, I'd like to just reiterate the great work that Belinda did in putting this together and leading it very quickly. There's a lot of documents around the world at the moment, and ours was meant to be a very practical, brief document just to highlight the key points. And really the 3 biggest points are, firstly, they're nothing new. Social distancing is very important in everything that we do. I think every year there's the word of the year, and I think this year it's going to be social distancing. It's going to be 2 words. I can almost guarantee it, because we'd never heard of this terminology before, but it's a simple role of keeping a distance between 2 people, which we normally say 1.5 meters, avoiding crowds, etc., etc. So that's a general recommendation. Whether you have a condition or not, everyone should be engaging in social distancing. The second is the simple thing of hand washing, which I used to tell my kids all the time, to wash your hands and wash your hands. And now it's almost a life-saving approach, because if you use soapy water to wash your hands, you get a good impact on the virus and prevent any spread of any viral particles, which is fantastic. So social distancing, hand washing, and the third one, which is particularly relevant to Australians because we're moving into winter, is the importance of getting the flu vaccination every year. And particularly this year, it's very important to get your flu vaccination to protect you against the flu, but also to protect your immune system to make sure you don't end up getting both viruses at the same time. So that'd be my three very basic recommendations, which are nothing new, but just to reinforce how important they are and what we've done a lot of in Australia of recent time.
Yeah, I thought your flu vaccine recommendation was a really important one that we haven't heard. I mean, we always encourage essentially all of our SADS families, as I'm sure you do, to get your flu vaccine every year. And there are and will continue to be, unfortunately, thousands and thousands of deaths throughout the world from influenza. So I think your guideline was actually one of the first to explicitly state, get the flu vaccine. So, and the social distancing, I kind of like to have switched it. I know social distancing is the word, but I have it 6 foot physical distancing, but stay really socially connected. And we're all challenged with how do we stay connected during this unique time that we're in. But Chris, you also wrote those guidelines to make sure the healthcare providers who are seeing our families or who might be seeing our families or who might take a nursing triage call from a SADS families, that you wanted to make sure that they were well aware of as the key things about SADS conditions and COVID-19. What's your top three for the healthcare providers out there?
I mean, in addition to what I've already mentioned, I think there are some important messages here as well. The first one is that there's been a lot of discussion about whether patients with SADS conditions should continue taking their medications, whether it be an ACE inhibitor, a beta blocker, whatever it might be. And the general message we want to get out there is that not to stop taking your regular medications. Do not stop taking your regular medications because the risk of something happening is likely to be higher than if you actually, stopping the medication would make the risk very high of complications occurring. So please keep taking your medications, interact with your cardiologist to make sure that they're all okay. But that's the first message because there's been talk about ACE inhibitors being stopped and other things. The second thing is that some of these conditions like Brugada Syndrome can be triggered by fevers. And it's just to remind people that when you get a fever and you've got one of these conditions, to treat fairly aggressively to try and bring that temperature down so that you don't get any complications of the particular condition like Brugada disease. So I think that's also very important. And the third area, which Mike, I think you're the expert in the world in, is to be wary of QT prolonging drugs at this time particularly, whether they're related to experimental therapies for the COVID-19 or any other medications at this time, to avoid QT prolonging drugs. I think, Mike, you might want to comment on that because you've been very prominent in this area for a long time. So, keep taking your medications, treat fevers aggressively, and be wary of QT prolonging drugs, whether they're therapies or other drugs which you might be starting to take for other reasons.
And are you encouraging the healthcare providers for the treatment of febrile illness in general or fevers to be using acetaminophen rather than ibuprofen? What's your thoughts on that?
Yeah, so there's a lot of discussion and points about the non-steroidal anti-inflammatories versus paracetamol in preliminary studies. And our general feeling is that there's probably enough evidence to say to stick to paracetamol if you can, because it seems to have a safer profile. I mean, I should have preempted everything I said earlier by saying that there's a lot of small studies out there looking at COVID-19 in different settings, but there's virtually no studies looking at genetic or inherited heart diseases or SADS conditions and COVID-19. So a lot of our recommendations are based on sort of expert opinion, I guess, and small bits of data that are available which make common sense.
I think that's great. And just for the audience, paracetamol is the same drug as acetaminophen or trade name Tylenol in the United States. I think the point you just said, Chris, is a really important one, isn't it, for our SADS families? Because about a month ago, I think we had a lot of SADS families who were incredibly frightened when they heard that patients with, quote, heart disease are at much greater risk of bad COVID-19 outcomes. And we started to get calls left and right saying, now, is long QT syndrome a heart disease? Is hypertrophic cardiomyopathy heart disease? And we had to do a lot of reassuring yet that, yes, by definition, it is a heart disease, but not the heart diseases that they were talking about or publishing on. And so it seems like right now, if you're otherwise healthy, but you have one of our genetic heart diseases, that your risk is no greater than yours or mine. Is that what you're reassuring your people down there as well?
I think so. I think almost all of the measures we mention in our brief document are relevant to normal people with no heart disease. And we had the same issue. I probably had 3 or 4 or 5 emails or calls every day from my patients saying, should I take any extra precautions? And almost all of them was to say to take the precautions that everyone else in the community is taking, which we've outlined already this morning or this evening.
Yeah, great. Well, Chris, let's turn to our SADS Facebook Live community, and I want to welcome everybody. And I'm looking over to the side. That's why you might see me off camera a little bit, everyone. But I see the questions coming in, and they're good ones, fast and furious. And so I like this question. I'm going to start with this one for you, Chris, from Tammy. Hi, Tammy. And she's wondering if this whole COVID-19 shutdown is affecting the testing for long QT. And I might extend that to, is the shutdown preventing families who need to see us for the possibility of their genetic heart condition? Are they not getting seen? And are we going to have some concerns about that or consequences from lack of access for those who need to get seen? Your thoughts?
Yeah, that's a great question, Tammy, and I think I speak on behalf of Mike and all of the cardiologists that deal with patients with these conditions, is that our patients are paramount. They're the focus of everything that we do, and it's an honor for me to see every patient face to face in that, sacred environment of the patient-doctor relationship, and we're missing that at the moment. So this afternoon I have a telehealth clinic where I zoom in and zoom out and see patients for 20 minutes, and that's it. So we're particularly concerned about making sure we maintain good levels of care for all our patients. So in that vein, what we've been doing is still seeing our patients by Zoom, having a chat, making sure there's no particular symptoms, making sure drug levels and appropriate therapies are in place. However, if there are features that are worrying me, for example, a long QT patient that might have had a syncopal episode or a pre-syncope, then we'll have measures to do some basic testing in controlled and protected environments within the hospital or within some of the local cardiac facilities, and get the ECG done, get the exercise test done, and make sure we appropriately manage the patient. But I have to say, most of the patients we've seen in the last 4 weeks or so by telehealth have been stable and well, and it's more a chat and reassurance that things are going okay and we'll get through this COVID-19 together.
Yeah, I think your point on telehealth is really interesting. I just, before coming on here, I had a great video consult with a really cool kid, never met him before, and his family. And this video consult is going to be part of our world, but like you, the sacred relationship of that patient right in front of us, nothing can replace that. And I sure hope that telehealth doesn't replace the specialness of the right there next to you interaction.
I couldn't agree more, Mike. And I don't know about you, but I like hugging my patients every now and then when they need a hug. And you can't really do that by Zoom.
Yeah, and now, last week's my face-to-face, because we're open to see patients. It's not really face-to-face, it's mask to mask right now. And it's not the same. Well, Zoe, that's great. Zoe, I like this one, Chris, from Zoe or Zoe. And she's wondering about the Brugada Syndrome and COVID-19. Is there anything about Brugada Syndrome itself or about SARS-CoV-2 infection that could be Brugada aggravating? Anything you'd want to tell her about that?
Yeah, I think the one point I'd make is to reinforce what I said a little bit earlier about treating fevers aggressively. we recommend that in all Brugada patients anyway, whether it's COVID-19 or not, to treat fevers very quickly and promptly, especially children with Brugada syndrome. But I guess in these times at the moment, we're even more reinforcing that message of avoiding fevers. And apart from the other things I mentioned, that would be the main thing I would comment on in terms of Brugada syndrome. I'm sure you've got anything to add, Mike, but...
Yeah, I guess the one that I'd be curious your thoughts of, because I've seen different responses or recommendations on our Brugada patients, they get fever, we lower fever, and I've heard some say, and we also want you to go stat to the emergency department if you have a febrile illness. And I don't know what you've done. I haven't been doing that. I've been having them lower their fever, but if they've been otherwise lifelong asymptomatic and it's just a more or less a dud, just having them lower fever, I'm just not sure that I want them dashing off to the emergency department environment where there are maybe all kinds of other febrile illnesses, including real COVID-19 coming through the local emergency department. So I've wrestled with the recommendation of should you rush to the emergency department. I'm curious what you and your team have settled in on that one.
Basically the same thing, Mike. I mean, there's everything we do in medicine is a balance between benefit and harm. And sending a patient who's been asymptomatic with a fever that settles down promptly with paracetamol to the emergency department, I would argue that potentially you're doing more harm than benefit. But of course, you assess every patient by patient, and if there are other things that worry you, they've had a sort of a pre-syncope or something like that, some other feature that might worry you that's not just the fever, or the fever hangs around for a while, then it might change my mind. But as a general rule, we agree with what you're doing, Mike.
Thanks, Chris. Summer, this is a great one from you. And Chris, her daughter has Timothy syndrome, and she has an ICD and is on mexiletine and propranolol 3 times a day. Do you think she's at higher risk? And I'll just preface this by saying for Summer and all of those from the Timothy Syndrome Alliance, we have devoted Friday's SADS Facebook Live, the start of it, for Timothy syndrome. We'll be having Dr. Molly Shaw and Dr. Paul Stockton with us, and we will do other questions as well, but we'll be starting it with a focus on Timothy syndrome. So that's a teaser between now and Friday. But in the meantime, for Summer, do you think she's necessarily at higher risk, or just follow all the things that you said already?
I don't see many kids at all. I'm an adult cardiologist, so I might defer to you, Mike, but I would have thought that taking the regular measures that we've already discussed would be the right way to go about things. But I'll be very honest and say that I only see patients above the age of 12. So specifically for children, I'd refer to someone, an expert like you.
Great. Well, I think what we'll have, Summer, is rest assured, keep taking your medicines. I don't think you're at any greater risk than any of my other long QT patients. We'll switch, Chris, to a question about ARVC. And Jason's wondering if there's special precautions that somebody who has ARVC and intrinsic lung disease or interstitial lung disease and scleroderma, should they be doing anything extra or special during this COVID-19 pandemic?
That's a great question. So ARVC, of course, is arrhythmogenic right ventricular cardiomyopathy, which is an inherited form of cardiomyopathy that generally affects the right side of the heart, but also the left. But for ARVC patients, as a general rule, we manage them like what we've already discussed in terms of keeping to take the medications, and all the social distancing measures and other features such as that. So for ARVC alone, that's how we would manage. We would manage it like a general population, but just with some special precautions about taking your medications, social distancing, etc., etc. The addition of some lung disease and scleroderma does complicate things a little bit because your risk is probably a bit higher of getting some sort of viral infection of the lungs, generally speaking, not just for COVID-19, but any time. So again, engaging the special measures we say are appropriate, and I don't think there's anything extra. I mean, some people have touted the idea that you should go into self-isolation if you're very, very worried about these conditions, but I think there's no evidence to be sure of that.
Great. Thanks, Chris. Well, here's a really good question. It's actually not a question from Bree, but you're going to like this one a lot, Chris. So Bree says that Chris is one of my doctors and he is amazing. So I'll simply say I concur.
Oh, Bree, that's lovely.
Yeah.
I mean, I have to say, it's an absolute honor looking after patients, and especially our genetic heart disease patients who, you grow up with. You see them grow up. They start off as teenagers or whatever, and they get older, they get married. You end up seeing their children. It's an honor to be a part of these families. I say that all the time at the clinic. It's my privilege to look after patients like Bree and others that have called in today.
That's I love that too. And so Celeste is wondering for us and for you whether we're still having new patients flying in to see us. And for us here at Mayo Clinic and our Winland Smith Rice Genetic Heart Rhythm Clinic, we're open. We're open now for combination, either what's called non-face-to-face video consults, like the young boy from Alabama who I just did about an hour ago, or the face-to-face one where they flew in from Anchorage, Alaska, like last Friday. So the point is, whether it's telehealth or live on campus, our program and Chris Semsarian's program, we're here for you. And so don't feel like you have to stay on the sidelines and wait to get your condition assessed. We can figure out how to do it. So thanks for that question, Celeste. Let's switch to a different one. Amanda's asking a good non-COVID-19 one. This might be different for our state, our country versus yours, Chris, but Amanda's wondering that before she has her son genetically tested, and she doesn't say which genetic heart condition, but I don't think it matters, that they were advised to get her son life insurance first, because it would be hard for him to get it later in life if the genetic test came back positive. And she's wondering if that's accurate information, if that's good information, any general guidance or advice that you would have about this. We get this question a lot, and I'm sure you do, depending on how life insurance is structured in your country. So what do you think, Chris?
Yeah, good question, Amanda. It's a very common question. We get asked this at the clinic almost every week when we're doing genetic testing at various levels. So it's not an uncommon question. The first thing I would say is that before you do any genetic testing, there needs to be clinical evaluation of the patient. So getting an echo or an ECG or whatever the appropriate test is, because if that's all normal, it might change your decision about doing a genetic test in your child, for example. But if you are going ahead with genetic testing of your child and you've got the appropriate genetic counselling undertaken before the test, as part of that genetic counselling, we discuss issues like life insurance. And what we generally tell people is to sort out your life insurance before you do the genetic testing, because at the moment in Australia, if you've got a policy in place, then there's no routine method of going back to the patient and asking for an update at this stage. And there's also a Discrimination Act, which is in its development to protect people like yourself and your child as well, under a certain amount of life insurance at the moment in Australia. But I think it's very different in different countries and different approaches. So that's the Australian evolving picture at the moment. But I would reinforce the point that anyone that has genetic testing, whether it's a child or an adult, must have some level of genetic counselling to explain the pros and cons of testing, what a positive result means, what a negative result means, and very important things like life insurance.
Great points. And I know in the United States, the genetic non-discrimination law that was passed several years ago made it discrimination or discriminatory against health insurance, but it did not include life insurance at that time. And so I think it's a wise question and a wise recommendation to sort of get your house in order, make sure you decided, do you want life insurance before you may or may not have a, quote, pre-existing. A quick question from somebody, I don't have her name or his name, has long QT syndrome, is 64, has high blood pressure, and is terrified. First, I would say, don't be terrified. Chris and I operate under a premise of be anxious for nothing. And you heard me before say # refuse to fear. And I think the important thing for your long QT is and your blood pressure is have your blood pressure treated and do all the things that Dr. Semsarian said about being aware, staying away, washing your hands, stay distant, washing your hands, all this stuff, wear a mask in public works. And the longer you and I can stay coronavirus free, the better, because we're learning what therapies might have a good efficacy signal and what therapies may or may not. So be prepared, be cautious, but please do not be terrified. Chris, while I'm scrolling through, anything you'd want to say to that person as well?
Yeah, just to reinforce the message that in long QT syndrome, to my knowledge, and I think to Mike's knowledge as well, there is no increased incidence of COVID-19 infection in long QT syndrome patients. So just to reinforce that there's no particular predisposition that makes you more likely to develop COVID-19 or contract COVID-19 if you have long QT syndrome.
Great.
Yep.
Allison has a great question for us, Chris.
Yeah.
And it's back to long QT, and we mentioned that Brugada patients, that in getting coronavirus infected may wake up or agitate their Brugada. That's why reducing the fever is critical. But long QT, are long QT patients at increased risk from COVID? Or whether is it only the potential that if they got COVID-19 and somebody chose to treat them with what I've called the Corona cocktail, that could get them in trouble? Which is it? Allison is wondering.
Yeah, Alison, I touched on that just a little while ago, but basically there is no evidence that patients with long QT syndrome have an increased risk of getting COVID-19. There's no evidence to support that. However, the long QT prolonging drugs have come to the fore because of the antimalarials that has been used in some small studies to try and treat COVID-19, and that's where the discussion has arisen about QT prolonging drugs. So again, it comes back to the basic principles. We always tell our long QT patients to avoid QT prolonging drugs. And so any medication which you're going to take during these times that may be additional or new, to check with the crediblemeds.org website, check with your genetic cardiologist. One thing I haven't mentioned so far, but is throughout our 2.5-page document from the Cardiac Society of Australia and New Zealand, is that always keep in touch with your genetic cardiologist, whether it's Mike Ackerman, Elijah Bear in the UK, Arthur Wilder in Amsterdam, Silvia Priori in Paris, or in Italy, wherever you are, you need the specialist in cardiology who knows your disease. I'm hopeless at looking after patients with blocked coronary arteries because I don't do that every day. I see those patients very uncommonly, and I find it very boring, to be perfectly honest. But I love genetic cardiology. I have some experience in it, and I have a network of people across the world that I can ask advice for. So make sure you keep in touch with your genetic cardiologist through these times if you have those sorts of questions, because they won't mind answering them. Whether you send an email, call them, whatever, I'm always open to discussion and interaction with patients.
Great. Thanks, Chris. And thanks, Allison, for that question. And I think just to encourage our long QT families and CPVT and ARVC, we still have not heard of, at the SADS Foundation, my entire clinic, Arthur Wilda's entire clinic, Elijah Bear's, Chris Semsarian's, of a single case of a long QT patient coming down with significant COVID-19. So again, keep us corona free for as long as we can, and we'll be learning what therapies will work if and when we need them. And so just, yes, it's out there, but not a single one across the globe have we been told. But in light of that, remember, the SADS Foundation just released a survey and sent it to our Facebook Live community about how are you dealing with all of this COVID-19 pandemic stuff. Are you infected and we don't know it just because you haven't told anybody? Or how are you navigating the emotional, mental health of this whole thing? And we want to know. We want to know, how are you thriving during this time? And so fill out that survey. Tell your fellow SADS friends and friend groups to fill out that survey. We have a couple minutes left, and let's do this one, Chris. Christine has we haven't really talked about CPVT, and Christine is wondering whether fever has any effect on CPVT, the way we've been talking about lowering fever because of Brugada concerns. Do you tell your CPVT families anything in particular about lowering fever? And if we don't, should we maybe?
Yeah, I have a small cohort of CPVT patients, so it's a small but very special cohort, and I must say we don't tell them about fever control in CPVT. CPVT is a rare condition which involves ventricular or bad arrhythmias related to exercise usually, and usually in young people. But I must say we don't I mean, as a general health measure, if you've got a fever, it's nice to bring it down, but we don't say anything especially for CPVT. But I'd be interested in your thoughts, Mike.
Yeah, we haven't either. And I talked with Arthur Wilde about that, who he oversees our international CPVT registry that we're both a part of. And we haven't, but I think it's Christine has an interesting point, because febrile illnesses are associated with sympathetic activity. Our heart rates are faster, but we actually don't have a single example of a CPVT triggered cardiac event in the setting of a febrile illness. So while it makes sense that why wouldn't we want to lower the fever, maybe we do anyway just because you feel better with a normal temperature, there's no evidence to suggest that fever is the equivalent of running down the track in an exercise generating or an exertional trigger way. So, and
if I can add some recent data that suggests that video gaming or playing video games in CPVT patients may trigger rhythm problems. So usually, as Mike said, it's always related to exercise levels, but things that might cause adrenergic stimuli, like a exciting game of Minecraft or whatever it might be, then that might stimulate some abnormal rhythms.
Yeah, and Chris, it's kind of interesting. The week after your paper came out about Minecraft video gaming and a CPVT event that you guys published, I had a patient who did his cardiac arrest. Well, became a patient afterwards, who did his cardiac arrest in the setting of a video game. So the video gaming certainly is adrenaline generating, they say. I've never done it, so I won't know, but
I should clarify, Christian Turner and his group at Westmead Hospital that published that paper, that short paper. But very interesting.
So again, the SADS Foundation, for those of you who are following the public chat, they posted the survey link, so check that out. And Linda is a great one to wrap it up with. Linda, I know who you are. You're welcome. So Linda is telling us, Chris, thank you, thank you, thank you. And so I want to thank Chris Semsarian, and I want to thank his team down in Sydney, Australia, and the team that he's assembled throughout the world for joining us today. And before I let you go, Chris, maybe with this time that we've had, kind of life is different, and life BC before Corona is very different than life now. And what are some of the things, or maybe share with our SADS community, something that's exciting you from a research question that your team is busy exploring, trying to address, keen on getting new answers to, that you want to just share with them that you guys are busy about while we're all quarantined or socially distanced?
Yeah, I mean, our focus will never change, Mike. Our focus is always about understanding why patients with genetic heart disease get their diseases, what are the risks of them dying suddenly, which is a rare event but a tragic event. And so we haven't really moved from that core value or that core principle of trying to understand how you get from a genetic change that you're born with to a complex disease which can lead to no symptoms, but in others may lead to very significant symptoms, heart failure, sudden death. So it's understanding that what we call heterogeneity, or the diversity in families, within families, and how do we best predict those that are going to have problems and those who are going to live to 100 and have no problems at all. And so a lot of our research at the moment is focusing on the utility of whole genome sequencing, where we can sequence all of our genome, 22,000 genes we can sequence at one time, and try and unlock some of the mysteries in terms of, do single genes cause these problems? Are they combinations of genes that cause problems? These are complex questions because our genetic makeup is complex, but we have great patients who very readily give up their blood samples, their clinical information to help us to try and answer those questions of, for example, two siblings in one family, both with the same genetic change causing, let's say, long QT syndrome. One lives to 100 and has no problems. One has a cardiac arrest at 20. What's the difference between those two people? And I guess a lot of our research and Mike's research and the holy grail is understanding how these genetic changes lead to such diverse diseases. So I guess that's a very broad answer to your question, but COVID-19 will come and go, but we've got a very strong focus on never having a SADS foundation where there's no sudden deaths in our community, and we can prevent and predict who will run into trouble and initiate early treatments.
Well, Chris, thank you. And when we have COVID-19 behind us, we would love to have you back on SADS Facebook Live, where you and I can have a chat about one of the research projects that you have asked and answered that you could share with our community. And so I do want to thank Chris Semsarian for joining us, getting up early this morning and being fully dressed in such a dapper way from head to toe. Thanks, Chris. And for all those of you out there on SADS Facebook Live, thanks for choosing to spend these 40 minutes with us. And some of you know that you've been watching my granddaughter grow up with me. So this is Jaden Ruby Lorraine, today's picture, 83 days old. I last saw her when she was 19 days old. So I'm going to drive in 2 weeks. I'm leaving isolation to intercept the kids and our granddaughter in Kansas City as they're leaving California, making their way over to southern Indiana. Our son is graduating from medical school in May, but without a graduation because, of course, COVID-19 canceled all medical school graduations. So join us on Friday. I'll give you an updated picture of Jaden. Whether you want to see her or not, I will provide that for you. So thanks for being with us today, everyone, and good night if for those of you where we're in the afternoon and evening, and have a great Tuesday morning, everybody, for all of you down under with my dear friend, Dr. Semsarian. Chris, take care. Blessings to you and blessings to all of you out there in our SADS Facebook community. Take care, everyone.
Thanks, Mike.